Okay, we're going to do a little bit of a deeper dive now into community behavioral health service billing. And again, I don't have a sense for where y'all are in terms of the services you provide, but Carrie and Andy and the folks that we spoke to putting this together, so the vast majority of folks here are going to be billing for some sort of behavioral health services or super services. So we thought we would do a little bit of a deeper dive on some of the specifics around billing for those services. So these are the questions that we kind of came up with as we were thinking through this, because there's been a lot of confusion and change, frankly, in mental health billing. So does the new Rule 140 replace the old 132 when we're billing Medicaid behavioral health services? Because there's been a lot of changes in terms of the regulatory environment. How do I bill if I'm a CMHC or this new category of agency called Behavioral Health Center? And then how do you bill for super services? So let's dive right in. So this is just same as the other one, even, whether you're a CMHC, a hospital, a physician, all those basic claim requirements are going to apply for behavioral health billing as well. So let's talk about Rule 132 and Rule 140. Prior to August 1st of 2018, we really used Rule 132 in the administrative code for billing Medicaid mental health services. So if you have services, or there were services delivered before the 1st of August in 2018, you billed according to Rule 132. There's a resource guide on the HFS website called the Service Definition and Reimbursement Guide that talks about all the different Rule 132 services, what type of professional can deliver them, et cetera, et cetera. But hopefully, you guys aren't holding claims from August 1st, 2018 from MCOs. So we're going to move on to what happened after August 1st. This is a very busy slide, so bear with me. So after August 1st, the Service Definition and Resource Guide went away or got sort of archived. And we now have the Community-Based Behavioral Services Reimbursement Guide. Again, on the HFS website, under the provider tab, a lot of detail, a lot of good information sitting there. So Rule 132 has changed, and for Medicaid billing purposes, Rule 132, from an MCO perspective, is really just a licensing and certification rule now. So it's really the requirements and the process to become a community mental health system, or community mental health center, pardon me. So it's really just a licensing rule as it relates to Medicaid billing. What we now have is Rule 140, and that's the rule you want to pay attention to because it is really focused on Medicaid billing for mental health services. So it did a number of things. It created a new category of service or a new category of agency called a behavioral health clinic, which is like the step-down unit from a community mental health center. And then it took all the sort of Medicaid Rule 132 rehab option services and put them under this new rule so that all Medicaid mental health services now fall under this Rule 140. So it just kind of consolidated, integrated, and hopefully in some ways simplified the whole system. In terms of general billing, this gets back to your enrollment type in MTAC. You have to have a designation, if you're a community mental health center or a behavioral health clinic, you're going to be in MTAC under that FAO category. You're assigned a different provider type. This goes into the claim. And then these are the taxonomy codes you're going to use. Are you guys familiar with taxonomy codes, by the way? There was some question as to whether, and I hope so because I'm not a super big expert on taxonomy codes other than where to find them and how to use them. But and again, so these are the different types of providers that are going to be billing for mental health services. Just make sure that you are registered appropriately in MTAC, and again, that crosses over into your universal roster. Obviously, you've got to be fully contracted and credentialed, again, with the MCO before you can start billing services. These services that they've set out in Rule 140 can only be delivered at the appropriately certified site. And the NPI number that you've registered in Impact and use on your claim will determine if you are certified for those services. So again, that Impact registration becomes really important. Really important, and I think most people have figured this out by now, but in case you're new, you cannot use the same NPI. So if you're an FQHC or even a CMHC, you can't use the same NPI to bill mental health services as you use to bill substance use disorder services. It has to be a separate NPI. So if you are currently a community mental health provider and with the opioid crisis going on, you think, you know what, we should start providing some of these substance use disorder services, you're going to have to apply to get a new NPI and register that NPI into Impact in the universal roster. Okay, so that's, and if you somehow use your mental health NPI and bill for a substance use service, it's going to get denied. If you have multiple sites, you're going to need to get multiply certified sites. You have to have a separate NPI for each certified site. Okay, so each site where you deliver services that's certified as a CMHC, you have to have a separate NPI for each of those sites. And we're going to talk a little bit about this. You can provide multiple units of the same service to the same client on the same day, but you have to roll those up on your claim. And we'll be going through some billing examples, and you'll see how to do that. And this is when the modifiers become really important in terms of how you put that on the claim. You can't list each one individually, or it's going to get rejected as a duplicate claim. The MCO is going to say, wait a minute, you're billing 5 times for the same service, and we're not going to accept that. Any questions on that? Okay. So in terms of how you submit the claim, there's 2 definitions that you need to understand: the billing provider and the rendering provider. Okay? The billing provider is the payee, where you want the money to go. So if you're agency X and you have 5 different sites, but your billing and claims and payments all come in to your sort of headquarters, that's the billing provider. So it's the payee. Where do you want that money to go? The rendering provider is the site where the service was actually delivered. So if you have a headquarter clinic and then you have some satellite clinics, and you're going to submit, the billing provider is Clinic A, and the rendering provider, the service, was actually provided over in Clinic B. That's the rendering provider. Okay, and there's going to be 2 separate NPIs. If the delivery of service was in that headquarter clinic, you don't have to fill out rendering provider. It's the same. If it's the same place, the same address, the same NPI, you just leave that blank. It's just if the service is provided in one of your other sites, you have to put in that as a rendering provider. Does that make sense? So it's all about where the service is delivered. That's your rendering provider, sort of self-explanatory. And then the billing provider is where you want that money to go. Who's going to get the explanation of payment and the check and the money. You may, if you're a CMHC or a mental health provider, have a professional who can bill individually, like a psychiatrist, say, or an APN that may be able to, if they weren't delivering the service under your umbrella, would be able to bill that as a separate service. You can still submit that claim on their behalf. They're going to be the rendering provider. So you're going to put the CMHC, the organizational entity in that billing provider, right? Because that's where you want the money to go, because you're paying the psychiatrist or the APN on your own. So you're going to put that in the billing provider field, which on the CMS 1500 is box 33. I know my CMS 1500. And you're going to use the NPI of the practitioner. So the psychiatrist or the APN or whoever is going to go in that rendering provider field, okay? And so then you just have to use, in terms of reimbursement, because it's a practitioner with his own or his or her own fee schedule. So a psychiatrist, obviously, as a medical doctor, there's practitioner fee schedule, which is going to be different reimbursement than what a CMHC would get paid. You just have to use the appropriate code for whatever service that psychiatrist or APN provided. Okay? You're going to use the same billing provider, rendering provider, but instead of using the CMHC HCPCS codes, you're going to use the practitioner ones. And most psychiatrists are, and it all depends on what your relationship is with the psychiatrist that you may be using part-time, whether you're paying them directly. Maybe they're billing on their own directly, but depends on the relationships you have. Does that make sense? Any questions? Everyone understand billing versus rendering? Yeah.
What if you're delivering services in the community, like in somebody's home?
We'll get to that. That's a location. And presumably, if you were doing that, we'll talk a little bit about that, but you would be billing through your headquarters, right? Because I'm assuming that the service in the community is coming out of that headquarters. So it's a location code that you put in. And again, those are all listed in the billing guide. So like 11 is office, there's one for school, there's one for residents, there's one, depending on where that service is delivered. So these are under Rule 140, as I said, the state kind of started grouping different types of services into 3 separate categories. There's Group A services, which any provider on this list can provide. So it could be a CMHC, a BHC, you as an individual LCSW or LCPC, anybody can provide the Group A services. Group B services, which are a little bit higher intensity services, can only be provided and will only be paid for to CMHCs or BHCs. This is where that provider specialty, subspecialty stuff comes in with impact. You need to register an impact as a CMHC with the appropriate certification, but you have to make sure in your impact registration that you've added these services as specialties, okay? Mobile crisis response, community, CST, all those services. You have to make sure that you are registered in impact and identify the specialties and subspecialties. Okay, that's what will determine your eligibility for payment. And then Group C services, it's really the ACT services and some psychosocial rehab. Only a CMHC can provide those services. It's fairly specialized, very, very intensive services, and the state has determined only CMHCs can provide those services. And again, you have to register an impact and indicate that you provide those services. Now, if you're a CMHC and you don't do ACT, that's fine. You're still a CMHC. But if you are a CMHC that wants to provide those ACT services or a CSR, or if you're a behavioral health clinic and you want to provide 2 or 3 of those services, you just have to make sure that you're designating those in impact. Okay? So that's where that impact registration starts to tie back to how you're going to be reimbursed. So each of those Group A, Group B, Group C has a list of HCPCS codes that are associated with them that determine what services fall under Group A services, Group B services, and Group C services. Each of those groups, the codes, the modifier, the time increments, there's a table within the billing guide that lays all those out very clearly, okay? Really easy to follow. Here's your Group A services, here's the HCPCS code, here's the modifier you're going to use depending on who delivered that service, and here's the time increment by unit, so like quarter hour, 30 minutes, whatever that time increment is of the service. Let's talk about the roll-up, and I'll do that by looking at a billing example. So say you're a CMHC, you have an MHP level staff member who's delivering some case management, delivers 2 units, so spends 30 minutes with the client on some case management in the office. But they do that at separate times of the day. So maybe the client comes in for 15 minutes in the morning, and the MHP is a little concerned, says, you know what, why don't you come back at the end of the day and we'll just check in and make sure everything's, hunky-dory. So it's the same service, it's still case management. One was at 9 o'clock, one was at 5 o'clock. Same provider, same staff person, same data service, same place of service, it's all the same. The provider is gonna bill on one line, so this is your first line of your claim. The HCPC code for case management mental health is T2016. The modifier is showing us as an MCO. HN shows that an MHP level staff member provided that service. So that's how we know if you have the wrong modifier in there and it's someone who's not qualified to provide that service, it's obviously going to deny the claim. So that modifier becomes really important. Place of service, this gets to your question, Jesse. Place of service is office, but you could be, could be in the community, you put the community code in there. And those place of service codes are also in the billing manual. And you deliver 2 units. So you see how they rolled it up? They didn't put T1016, HN, 1 unit, and then put another line with the same information with 1 unit. Because in the MCO's mind, that means you're double billing. You're billing for the same service twice. That's a duplicate claim. It's going to spit it out. Okay? Let's look at another example. So in this example, again, MHP level staff, they're at a CMHC. This is a Group B service. So this is one that only a CMHC or a BHC can provide. They're going to provide 2 units of crisis intervention in the office to a single recipient. Later that day, the client returns to the same CMHC, but Joe Smith from the morning has gone home, and now Jane Doe is working, and she provides 2 additional units of crisis intervention. So the provider is going to submit a bill, and they put it on 2 different lines. Crisis intervention code is H2011. They're both MHPs, so the modifier is correct. Both took place in the office, and they both provided 2 units of service. Is that the correct way to bill? You're good. No. That's going to get rejected as, this will get adjudicated. That's fine, but it's going to spit this one out and say, wait a minute, that's a duplicate. What you have to do, again, same HCPC code, same modifier, because even though it's 2 different people, they're both MHP, right? So that's going to determine the reimbursement rate in the office, but you provided 4 units of service. So the thing to look for is if you look down your claim and you're seeing duplication or a line that looks the same as the one above it, that's when you know you're going to have to roll it up because it's going to be spit out as a duplicate claim. Does that make sense? I keep saying, does that make sense? Not that this makes sense, right? But that's the roll up, right? So you can provide multiple, same service, same recipient, same location. It's just how you bill it. You have to make sure you're rolling it up so that it's in one line. Last one. So this is another CMHC, MHP level staff. They're going to provide 3 units, and I got to make sure because in one of these examples, your handout was incorrect. So let me just make sure that I tell you which one. I think it was in billing example 1, I'm not sure what happened, but on your sheet, it says TF as the modifier. Please change that, it's HN. I'm not sure how TF got in there, but I just really want to make sure that TF is a completely different type of provider, so that's where that came from. So we've got an MHP level staff providing 3 units of IATP, Integrated Assessment and Treatment Planning. That's a Group A service, so whether you're a CMHC or just a psychologist or LCSW, MSW in private practice, this is Group A, just happens to be at a CMHC. They're going to provide 3 units to a single recipient. And then later that day, a QMHP at the same place provides an additional unit of IATP. Also in the same office, same recipient, same day. So the provider submits a claim. with two lines. One showing same HCPC code, because it's still integrated assessment and treatment planning. You got your HN modifier for the MHP. Your QMHP is modifier HO. Same office. The MHP did 3 units. The QMHP did 1 unit. Do you think that's going to pass muster? It is. You guys are good. And again, you can see it's a different modifier, right? So even though it's the same HCPC code, same place of service, those are different provider types providing the service, and that's where those modifiers come in. And again, in the billing guide, there's a table of all the modifiers, MHP, MSW, LCPC, CAPC, they're all listed with the appropriate modifier. So that's community behavioral health services. I would, if you are going to be billing for CBS services, definitely take a look. Not yet, because there actually is a corrected version coming out hopefully within the next week to that section of the billing manual. We caught some typos in that modifier problem. But definitely dig in, because it has some really simple, easy to follow tables of provider types, service types, HCPC codes, modifiers, et cetera. So I think it's very, simply laid out for folks to kind of follow along. Super services have been a bit in limbo. All I can tell you right now is you just have to follow the super billing guide that HFS, we do not have this in the billing guide yet. You have to follow what is posted on the HFS website related to super services. We have been working with the state for, I don't know, gosh, it's gotta be close to a year now, on trying to figure out, without getting into a lot of nerdy, witty, nitty-gritty, what the plans have to submit to the state. They're called encounters, so every claim, every service gets submitted into the state through what's called an encounter. And we just can't figure out how to do that with the way super services are billed. So I think we're getting close to a solution, but I would say in the next month to 6 weeks, you should see a super billing guide come out. But until then, just follow the HFS guidelines for super billing, okay? And again, you have to have a separate NPI. If you are a current mental health provider and you're thinking, oh, I think we're gonna add this service array, you are gonna have a new NPI and a new registration and impact, okay? All right, any questions on that? And I apologize for those of you who are not mental health billers in the audience that had to sit through that.
Back to the multiple.
I hear you, but I don't see you.
Here I am.
Oh, thank you, I'm sorry.
If we want to be a BHC, and you were
yes.
talking about NPIs for each site, if we have 4, do I have to have 4 NPIs?
Yeah.
Okay, thank you. Here.
Yeah. But can I ask you a question?
Sure.
Have you begun that process to be a BHC?
No.
So here's what I'll say about BHCs, and Carrie can chime in. This was a new category of service that again, this is Lindsay Artola speaking, not anybody else, so take that for what it's worth. I think is a really important category of service and a really important service level entity, especially for child welfare providers. Because child welfare providers are providing some of those higher intensity services to their clients, but they're not going to need to be doing ACT and the psychosocial, like some of those for the seriously mental ill that CMHCs are doing and require a lot of resources and training. So I think it's a really important category of service. I think the state, with the change in administration, has taken a different view on whether they want BHCs to happen or not. Now, we've done a lot of advocacy around the importance of this, am I right, Carrie, on like, we need to get this moving, especially as youth care comes online. So we've seen some movement, but I know there was a number of providers that had submitted their applications and just never heard anything back from the state. And we're sort of in this limbo. But now I think there's finally some movement going to get people out to do a site visit and finish the licensure requirements. But just want to give you the heads up. I do think it's a really important category of service, especially for those youth service providers that do a lot of mental health and counseling and crisis intervention. But I'm glad to hear that those site visits are starting to happen. But just be warned, and if you, again, I would defer to Carrie, but if you have issues or you find it stalling, please let Carrie know and we can talk to the state again. I think what happened was a lot of the folks that applied to be BHC were not the folks the state really wanted to apply to be BHCs. But I think their thinking is shifting a little bit now, so. Anybody else? All right, I think that's it for me. Thank you for your patience.